Ben, how are you?
Well,
I'm laughing because I made a mistake. I'm Mr. Dyslexic here, and I sometimes switch the brothers' names. How are you feeling today?
I'm excellent. Just
What's
been
going on?
having a little bit of a knee issue,
Okay.
actually. So a couple years back, just real quick, I had been in a BMX accident and I had missed my gap, and I had actually ended up tearing my MCL, meniscus, and my ACL. And going through physical therapy and everything, I'm about I bounced back. But recently, I just had an injury where I had fallen back, and this leg was hyperextended when I came back. So it kind of sort of centered around that knee again and brought me back to that. Not to the severity of that, but it's still complications within the knee there.
Are you able to extend it? Or are you able to lock it out?
I'm able to lock it out and everything.
Now we're jumping ahead a little bit, folks. I actually worked on Ben a week ago,
Yes.
and it was bad.
Yeah.
You couldn't lock out your knee.
Couldn't lock out it, right.
So this is our second visit. So what I'm going to do today is, once again, I have a lot of people who ask me how I handle knee issues. Once again, I want to be real clear about this. People end up fixating on certain things. For example, if you have a knee problem, you only have a knee problem. Well, the truth is, Ben, as I explained to you the first time I worked on you, usually if you have a knee problem, you got lots of other issues. What I mean by that is the poor knee is like the middle child. It takes the beating if you have foot and ankle issues. It takes the beating if you've got hip issues. So if you have fallen and injured something, somebody pushed you down, you're skiing, you fall directly on your knee, you get a rip and tear, so to speak, injury, that's one thing. And you did have that. But mostly with knee injuries, they aren't just knee injuries. You have complications of the feet, the ankle, and the hip.
Oh, absolutely. I mean, it's centered around my knee, but because of the nervous system and everything, it actually has affected the entire leg. I mean, it all the way down to ankle, foot. I've sometimes felt it up to here, and so it definitely like.
Well, let's do this, and please, David. I'm going to have you make sure you get the angles right, because I want our viewing audience to really see very, very clearly what I'm talking about here, okay? And
Absolutely.
you can come about right here. I'm going to have you touch your shoulder here.
Okay.
Now, we're going to see a number of things. I'm going to lift you up here, and I'm going to demonstrate a number of things here. So we're going to check. We're going to see if he has proper internal rotation, and look at this. He's got no internal rotation of his femur here. I can't go like this. Now, look at this. I'm going to put your...
Yeah.
Thank you, Ben.
Okay.
Do you see how this internally rotates? Look at this. You feel that?
Yeah.
So that means we
Yeah.
got a hip issue and we got a knee issue. Now I'm going to raise you up here a little bit, okay? And I should have had you take off your shoe first, but let's go here. Do you have internal rotation here? You got a little bit, but not enough.
Yeah.
Look at this. Do you see how good that is?
Right.
And you have no pain there.
But you got to remember from what 4 or 5 days ago,
Yeah.
it was even worse.
Oh,
than that, so
you had zero.
it was- yeah.
So this is a good improvement.
Right.
But we're gonna demonstrate how to improve these. So look at this. Very poor internal rotation still. Better than it was. It's
Yeah.
not frozen. Look at this.
Right.
Ben, look at this. Almost essentially no external rotation. Go to the unaffected side and look at this. Can you get that? See how good that is? Now look at this. Here, nothing. Would you take off your shoes
Yeah.
real quickly? And I'm going to demonstrate some interesting things here. I'm going to go to the end here, and David, you're going to come here. I want them to see it from this
All right.
vantage point here, okay? So in a second, he's going to kick those off.
You
and
would
then we're gonna line-
ask me to take my shoes off when I'm wearing the
You
high
can even
tops
pause
today.
it. You want to just pause it real
Oh
quick?
no,
You
no,
can?
I have
You got
them
them off a second?
Yeah, that's gonna be quick.
No worries.
And so, there
Now,
we go. Do you want them off on both?
yeah,
Okay.
we're going to do both sides.
Okay.
Another thing, when you're taking care of somebody's lower extremity, upper extremity, please, folks, always know there's no such thing as one side being affected. If you got a knee problem on one side, it's just how long is it going to be before you have a knee problem on the other side. Let's have you lie right in your back here.
Okay.
Head down here. I'm recording. Please. Okay, this is very important. Now look at this. We've got no eversion here at all. That means I can't take his calcaneus, his heel bone, this way at all. He has zero. Okay. Now we're going to go this way. Do you see how this moves, David? Can you get that on the camera? This moves this way. So his heel is moving. It's tight on this side, but it's moving. Now we go back here. Look at this. Here, nothing. Watch my hand. Nothing. Now, one of the problems when you have issues of the knee, you got to check not just the knee, you got to check the hip, you got to check all things connected to it. This is the fibula, no motion here. No spring of the fibula here. That's the thin bone that goes along here, and none here at all. Now, doctors will tell you it's non-weight bearing and it doesn't affect anything. Absolutely untrue. Okay, you're going to find as soon as I start clearing these distortions, these somatic distortions, he's going to have massive improvements in strength and in mobility. David, push against me here. Ben, excuse me, I'm so sorry. Ben, David, catch this. Push against me here. There you go.
Gotcha.
Look at this. Look at this. No strength at all. You see this? We've got to correct that. That means he's not walking properly. He's not doing an effective gait pattern here because his heel's locked up and he has no strength here at the big toe. It makes him very unstable. It's going to create a furthering of the distortions of the foot, ankle, knee, and hip. So here's what we're going to do. We're going to make a huge improvement of his knee just by correcting these mechanical distortions of the foot. So look at this. No motion here of his metatarsals. No motion at all. See this? Can you see that? We go here. See, there's spring. You see this? Beautiful spring. This is very important because his foot is rigid. So he's going to have all kinds of inflammatory issues. Now, I'm going to come in here. David, I'm going to come in here. I'm going to strip out the arch. You're going to hear a pop. Bingo. What I did is the distal metatarsal heads were collapsed. Now look at the difference here in motion. Look at this. We got spring here. Not enough here. We got to set a lot of the components here. What I'm going to do, and I'm sorry, I'm hurrying a little bit. I can do this another time. I've got an appointment I got to get to, but I wanted to show this because Ben had a horribly difficult time with his knee. When he came in last week, his knee was stuck like this. He couldn't even go into a neutral position. Am I correct, Ben?
Yeah, absolutely. It was, and it was painful. It didn't feel good the entire time either.
So what we're going to do is interesting. We're going to do what's called a long axis extension mobilization here. I'm going to take this anterior directed tibia and I'm going to drive it down and up. When I do that, he's going to have a lot of his ankle and heel eversion come back. Also going to take these metatarsal heads, going to reset them, the subtalar joint and the calcaneus. This is going to be a fantastic move. We're going to correct 4 things at one time. We're going to drop here, we're going to pull here, we're going to set here on the heel. Here we go. Count of 3, priming, 1, 2, 3, and again, there we go. He was really stuck. Now, observe this. Here's the distal fib head. Look at that beautiful, gorgeous motion there. See how nice that is? He's going to love this because his joints will spring again. Now, what do you think of this? Look at this. Look at how well these bones are moving now. Feel how nice that is? Look at this. Here, look, check out this calcaneus here. Look at this. Fantastic. Better than this side now. Better than this side. Now we're going to correct this side. He has a lesser degree of distortion on this side. That's because this side is directing, of course, how he walks. And this pattern is going to screw up this pattern as well. It's just this isn't going to be as severe. So here we go. Same correction here. There we go. I don't need to pull that hard, but he's very strong and very athletic. There we go. Now, what do you think of this? Look at this. How does that feel? Like somebody gave you new feet and a new ankle?
You know, it's almost like you get so used to walking on it incorrectly that when you actually get it reset and it's even again, it's a
feels like a different, like a
it's
different.
like 200% improvement.
Yeah.
I mean, it's.
Now we're going to do some really neat things here. One of the things that almost nobody I know pays attention to is how the kneecap tracks. This is crazy important because the kneecap has to assume a certain position to get mechanical advantage and to make sure that everything works here ideally. Okay, if it doesn't, then you're going to have trouble squatting, you're going to have trouble going into a lunge, you're going to have trouble bending at the knee, the whole bit. Like his kneecap doesn't move this way. Feel how stuck that is?
Yeah.
Now it'll go this way nicely. Watch this. I'm going to come up here, you're going to hear the pop. Focus right here for me, okay, David? Here we go, and pop. One more pop. That's his kneecap. Now, look at this. That's incredible. This is so critically important. On a more lengthy film or video, I'll explain why that's so important, but look at this, how well that's moving. Now we got to get one more thing. Now watch this. I'm going to come up here, and I'm going to take this part of my forearm. We're going to reset an anterior fibula here. So we listen to the pop. Little one. Good. What do you think of that now? Isn't that incredible?
It absolutely is.
Now,
Absolutely.
I'm going to use, this is called a drop table. I'm going to run a high velocity force through his lower abdomen so he can reset his psoas muscle, iliacus muscle. And now we're going to get him hanging there. I'm sorry, this is going to be loud. I'm going to get right here. Pop and roll. And here we go. Pop and roll. Now, what do you think about this?
It's incredible.
Unbelievable. Now, folks,
I mean,
here's what's really interesting. Did I do anything directly other than kneecap to his knee? I didn't do anything. Now, we're going to check it. We're going to see how well it works. But this is what I'm talking about. I corrected the ankle, the foot distortions, the fibula patterns that were dysfunctional, proximal end, distal end. Now we're going to recheck the knee. But I haven't even done anything directly to the knee. Look at this. What do you think of that? I want you to capture that. Got that, David? Does that work internally and externally better?
Yes.
That's like a new knee.
Yeah.
The knee he presented with is a knee that's going to blow out and he'll injure medial meniscus or tear it into your cruciate again. This is fabulous.
Yeah.
Now walk on that, sir, and tell me what you think of that. And I'll do the other side, but we'll do it off camera.
Let's see. Just,
3.
Ben, now how does that feel?
it's actually, I feel like I have 100% of my movement back, and it really helps with, I mean, I'm active all the time. I'm
Right.
probably lifting weights every day just about.
Yep.
I certainly haven't been able to do any running because of the leg injuries,
No.
but I run almost every day.
Yeah.
And now, knowing that I have it back 100%, I'm going to be doing all that stuff, my sets and everything correctly in the
Perfect.
correct form
Yep.
without having that offset.
Ben, I want everybody, thank you for that. I so appreciate
Yeah.
that. That's a knee
Oh,
that
thank
works
you.
well now. You're very, very well.
Yeah.
Folks, what I want
Yeah.
you to understand is unless you've fallen on a knee, somehow you fell down, you tripped, you stumbled, or you were playing football or soccer and you fell directly on a knee because of a push or a slip, then of course you got to look directly at the knee. Many times knee problems, even if you do fall on it, people do things that lock up the relationship between the hip, the knee, the ankle, and the foot. And if you don't get rid of those distortions, I don't care if you have surgery, I don't care how much you work on the spine, I don't care how much you work on the knee directly. If you don't correct those other somatic dysfunctional areas, the knee problem is just going to be back on your doorstep.
Yeah.
Okay? Make sure you look at the other lower body components. Now what I'm going to do, and I'm not going to film this because we've probably gone a few minutes already. Now I'm going to take care of this. If you have a hip that's that off, you're going to have a pelvic issue that's off, the spine will be off, and the nerves that innervate the muscles that control the lower extremities are going to be off as well. We'll correct that now, but we'll do it off film. Thank you for watching. If there are any others, I know I'm doing this because a number of you said, can you show me work on some hip or some knee issues? If you have any other issues you'd like me to focus on, please let me know. Leave a message after you watch this, and I'll be sure to find somebody that I can do them with. Thank you for watching me. Happy Memorial Day, all. And David, thank you for filming me. Ben, thank you for letting me work on you.
Thank you.
bet.
Thank you for getting me back.
You bet. Sit right here and I'll correct the rest of you. What do you think of that?